Hey everybody, welcome back to the ECG of the day. My name is Reed. Before we get started, don't forget to download the PDF of today's document for the ECG down in the description. And feel free to like, subscribe, and comment to help support the channel and promote the videos. So let's get started. So the first thing we're going to do is we're going to look at the forest. And the trees of the forest are our QRS complexes. Maybe I'll start right here in this lead 2 rhythm strip. And if I zoom in, we notice kind of right off the bat, we've got this narrow complex QRS that appears to be very rapid. It's also very regular, and if you just scan through, you can see that that regularity kind of maintains itself. If we take a look at the rate here, we see if I start with a QRS on a solid line, my rate is, if I start here, excuse me, that's not the one I was looking for. If we start here, we see our rate would be 300, 150, so somewhere between 150 and 300 beats per minute. I would say maybe 200 to 210 beats per minute. So we're going to call this tachycardia, and it's a narrow complex. And so what's our differential for narrow complex tachycardias? Well, we could say we've got AFib or flutter. We've got sinus tachycardia. We've got SVT, which we could say would be maybe an AV nodal reentry tachycardia or an AV reentry tachycardia, to just name a few. And so as we start to narrow down what we think this is, we've got a rate of 200 to 210 beats per minute. And so unless this was an infant, which it's not, then I would say this is unlikely to be a sinus tachycardia, because the sinus node typically doesn't beat that fast. And if we look in front of all of our narrow complex QRSs, I don't necessarily see P waves that are incredibly distinct to make me think that this is a sinus tachycardia. And so because this is a narrow complex, the reason why I say that my differential includes all of these atrial or supraventricular tachyarrhythmias is because if it's narrow, we know it's taking the normal His-Purkinje system from our AV node down into the ventricles for rapid depolarization of the ventricles. So we know this arrhythmia has to be coming from the AV node or higher. And so let's take a look and see what we think is going on. And so maybe I'll start off by looking at what is the atria doing. And I don't see any distinct necessarily like sinus P waves, but what I do see, and remember, so first thing I want you to remember is that T waves are usually smooth, and P waves are usually like very sharp compared to T's. So I like to look for any sharp deflections, and if I look here, what you'll notice is that we've got these little sharp deflections kind of on the T wave. If you can see those, I would say that is more indicative of atrial activity that is superimposed on this T wave. And so one way that you can differentiate this between this and other arrhythmias is that where is that atrial activity relative to the ventricular activity? So I would say that this is unlikely to be atrial flutter. At 200 beats per minute, it would likely have to be a 1-to-1 atrial flutter. And I don't necessarily see any flutter type sawtooth patterns. And I would say it's unlikely to be atrial fibrillation because we know that atrial fibrillation would be somewhat irregular. And so we can kind of cross those off our list. And so we're here with a supraventricular tachycardia. And the best way to determine the difference in AVRT versus AVNRT is to take a look at the RP interval, which is kind of the distance between the R and this R and P. And so the P wave we're saying is this little spike. And so that distance there, we would say that distance in this case, I'll do it in red, that distance is greater than 70 to 80 milliseconds. Is greater than that. So that tells me that the atrial contraction or atrial depolarization that we're seeing here is occurring not perfectly synchronized with the ventricular activation. And so how does that help me determine if this is AV-RT versus AV-NRT? Well, remember that AV nodal reentry tachycardia, AV-NRT, occurs when a reentry circuit occurs in the AV node itself. And so you have this reentry circuit where the signal goes around and around the AV node in the slow and the fast pathways, and it sends signal down with every pass, up and down, almost simultaneously. And so AV-NRT, because of that, AV-NRT has a short RP interval, right? Because it's occurring rapidly. AV-NRT, AV reentry tachycardia, occurs when there is some type of accessory pathway, say it's here, between the atria and the ventricles. And so you get a reentry circuit where you have signal going down the AV node, depolarizing the ventricles, but also re-entering into the atria and depolarizing the atria, and then it occurs again, down, depolarize, comes back up through that accessory pathway. And notice that it's going to take some time for that signal to travel from the ventricles back through the atria. And so that's why AV reentry tachycardia has a longer RP interval. So what is this rhythm? We get an AV reentry tachycardia as our diagnosis, AV reentry tachycardia, but we're not done. Let's take a look at the QRS and just make sure that QRS axis is what we think it should be. My QRS is upright in lead 1. It's upright in AVF, so my QRS axis is going down and to the left. It's a narrow QRS, and so we know that it's going down the AV node that way, and so we can actually call this an orthodromic AVRT. I don't see any conduction abnormalities that would make me think that there's ventricular hypertrophy, and because it's narrow, there is definitely no bundle branch blocks. I can look for my ST segments to look for any ischemia. I can also look for pathological Q waves to see if there's any previous myocardial infarctions. I don't see either of those. And so when I put this all together, I get a regular narrow complex tachycardia that is going quite fast. I estimated maybe 200, 210 beats per minute. You can do the math yourself and get the exact rate. Not so concerned about that here. And so we said that this is an orthodromic AV reentry tachycardia. And so a couple treatments for this would be, medications that block the AV node, or if the person is unstable, you can do like a synchronized cardioversion with electricity. Ultimately, this person is going to need an electrophysiologic study, right? Because we said that this AVRT relies on an accessory pathway. We need to identify this in the EP lab and ablate it so this person doesn't have this complication again. So hope this helps. If you have any questions, throw them in the comments. And if not, subscribe to the channel. We'll see you tomorrow. Have a great day.